Good morning, everyone. Bob Ravenscroft, the Vice President for Advancement, here for today's media briefing. We have back with us Dr. Jim Nora, and he's going to share a little bit about the strains that are emerging. There have been a lot of questions on that, so we want you to hear directly from Dr. Nora precisely what's going on here, rather than, wherever you're grabbing information these days, you're going to get it straight from him. So I'll go through the stats quick. And then we're going to talk just a little bit about vaccination, and then we'll turn it over to Dr. Nora. Midnight census is 515 patients, so we remain quite busy here. We currently have 78 COVID-19 patients in here. Of those, you guys are very familiar with the categories right now. 59 of them are positive, and we have 17 that are still hospitalized, still quite ill, but they've, extended beyond where they're still contagious. And then there's 2 others that were just pending the results, but they're clinically positive. So 78 total. As you can see from the levels of care, there's the number of patients, but 14 of those patients are in the intensive care unit, and of those 9 of them are ventilated. Kind of evening out. Lancaster is eclipsing greater Nebraska counties and Kansas and Iowa a little bit more so. So we have 48 patients from Lancaster County and 30 are from elsewhere. A little bit on the vaccination. Things continue to go well with our second dose here for those that were in the early parts of Wave 1 of our Phase A. Our focus remains, I just want to keep repeating this, on our employees and our medical staff, and we were also able to accommodate Lincoln Lancaster County Health Department's request to vaccinate other community medical office personnel, and this continues. Lots of questions coming in. Just want to reiterate, we are working off a health department guidance. We will jump in when we can, and they determine what the next allocation to what the priority groups are. We do not have extra vaccine for the public. If we do get it, and if we are asked to be part of the general public vaccination, you will hear it directly from us. So really all other questions should be directed elsewhere. We have set up an information page on our website. If you just go to bryanhealth.org/vaccine, we will always put the most updated information from the community there for what priority groups are firing, where they can go, and what they need to do.
Thanks for having me today. This is a great topic, very timely. This is lots of questions come up about mutations and how it might relate to things like the vaccines. Since we were just talking about vaccines, let me just pause to say that I have been fortunate to get both of my vaccines. I got my second installment on Monday. It went very well. The first injection was even less painful than the typical flu shot. Flu shot I don't think of as being terribly painful, but sometimes they are. But it was less than a flu shot. Round 2 was maybe a little bit more than a flu shot. And I think within 24 hours after round 2, I was back to normal. The bottom line is, it went very smoothly, and at least for me, no bad side effects. Most of the folks I've talked to have said the same thing. In fact, everyone I've talked to has not had bad side effects. So hopefully that will be the case for all that get it. So speaking of COVID, when you get the vaccine, the advancement office here too, also they gave me this cool little pin. Everyone gets a pin when they get their second installment, and this particular pin doesn't have a COVID meme on it, but the other one that was an option has a COVID meme on it, which is a circle with all kinds of spikes. And today's talk is a little bit more technical, so I'm going to be going into some of the details about those spikes, but I think my goal is to make it relevant to what's practical in terms of clinical applications, vaccines, laboratory testing, things like that. So on this first slide here, there's an image of COVID, SARS-CoV-2. And these images, by the way, are courtesy of NIAID, which is the National Institute for Allergy and Infectious Disease, one of the 27 institutes at the National Institutes of Health. These yellow gold colored organisms, those are, that's coronavirus. And you'll notice that they really aren't all the same size. They're a diverse population. Some are tiny, some are much larger, and they're not circles, they're spheres, and they're really blobs. They're not full inflated spheres. They're blobs kind of pushed in on one side. On this particular image, you can't even see the spike protein. So sometimes on the meme, the COVID meme that we see all the time, the spike protein gets overdrawn a little bit, but nevertheless, it is a very important part of the organism. So moving on to the next slide, I wanted to talk a little bit about mutations. And when we're talking about mutations, and whether it's mutations in a virus or a bacteria, we're talking about the change of a single base. In the case of an RNA virus, it's a nucleotide base. And there are multiple types of mutations. This list isn't meant to be exhaustive, but the most common type is probably a synonymous substitution. And what this means is that one of the bases has changed. So it's a different base and a different nucleotide. And that change doesn't actually change much of anything. The actual genetic code has changed, but the codon, which in turn helps to tell the molecular machinery of the cell what amino acid to attach to the growing string of proteins, that doesn't change. So, for example, with there may be asparagine as an amino acid, and you can code for this with AAC as one codon, but you can also do AAU, and so you can change the C to the U, and that doesn't cause any change whatsoever. So those are really benign mutations. They don't change anything. A deletion is another type of mutation where a particular codon is deleted, and so in this structure, this protein, which is just a string of amino acids that are all strung together, some of them are just chopped out. And usually that doesn't make too much of a difference in terms of how things work, and that's important in terms of worrying about, is the vaccine going to work? Are we going to have trouble with lab tests, things like that? Probably the most concerning type of mutation is what's called a non-synonymous substitution, and what that means is that one of the nucleotide bases has changed, and that in turn has changed the codon, which in turn changes the amino acid. So when the amino acid, which is just one of strung together on this protein, changes, there is the possibility that the entire structure of the protein changes. In many cases, it's just a small change, but in some cases, it can be a large change. So when we're talking about mutations, ultimately what we're thinking about is a change in the structure of the proteins produced by the virus. I don't know if we can have the next slide. So mutations with RNA viruses are common. SARS-CoV-2 is an RNA virus. There are other RNA viruses, HIV, influenza. Mutations with those are far more common than with SARS-CoV-2. So while it's true in general that RNA viruses mutate on a regular basis, SARS-CoV-2 tends to mutate less than many other RNA viruses. So the CDC estimates that there's about one mutation every 2 weeks. There are probably about 4,000 mutations that have occurred since the pandemic began. And then I wanted to go over the timeline of some of the well-known mutations. And the point is, with this especially, is that we know, we're hearing a lot right now about a mutation, but it's really important to realize mutations are not new. They have been going on from the very start, and they will continue to go on. So the fact that we're seeing mutations is absolutely nothing new. So probably one of the most important early mutations was D614G, and that's a fancy technical term just saying that the position 614 of the spike protein changed from D, which is aspartic acid, to G, which is glycine. And this happened probably in January of this year and was really first recognized in Italy. The thought was that this greatly increased the ability of this virus to transmit. And so for that reason, that's one of the reasons that was put out for, why did this virus just tear through Italy and parts of Europe and then parts of the United States. Originally, the virus that came to the United States on the West Coast was the D variety, so position 614 had aspartic acid, but the majority of the virus that came to the East Coast had the G at position 614, so the glycine. Now, the predominant form is the G form, and that's worldwide, and since July, that's been the dominant form. Another relatively famous mutation is called the cluster 5 mutation, and this occurred in Denmark in November 2020. And you may remember this in the news with association with mink farms. So there were a bunch of mink, and this particular coronavirus, which can interact with human coronavirus, developed a mutation in the spike protein. And the government there took drastic action, and they culled all of these mink with the fear that maybe this new mutation would potentially lead to concerns about the vaccine not taking. So, there's definitely been some concern about mutations, and whether that was the right thing to do or not, we don't know. But that's the action that was taken. The two mutations I'll focus most on are the one in the United Kingdom and then also one in South Africa. And the United Kingdom mutation was identified in early December, and it goes by many names, and it's often referred to as B117. I'm just going to call it the United Kingdom variant, but that emerged in early December. And then in late December, there's another variant that emerged completely independently in South Africa, and I'll just refer to that as the South African variant. So if we can have the next slide. Why do we care about mutations? And there are several reasons. We wonder about will this mutation affect the ability of the virus to be transmitted? And ultimately, from an evolutionary standpoint, the virus wants to be as transmissible as possible. So it's pretty natural for it to tend towards being transmissible. Can the mutation affect virulence, how deadly the virus is? And ultimately, from an evolutionary standpoint, the virus wants to head towards being less virulent, because if it kills its host, then that particular version of the virus is done with. Now, that doesn't mean that a particular mutation can't make the virus more virulent in the short term, but long term, viruses tend to be more easily transmissible and less virulent. So those are some clinical concerns we have, or epidemiologic concerns. There are also diagnostic and management concerns, and one would be, does our lab testing pick up these new mutants, these variants? Do our treatments work for these new variants? And probably one of the most important ones is, does this vaccine that we're holding out all this hope for, will that work for the new variants? Sorry, if I can have the next slide. So let me talk a little bit more about the UK variant here. So this emerged in early December. It has 23 mutations, and 17 of these affect the structure of the virus. So the one that gets thrown out most in terms of the structural changes is the N501Y, and the S in front of it indicates this is something that occurs in the spike protein, and it's at position 501, and the N is asparagine, and that's converted to tyrosine. So just a substitution of an amino acid. Tyrosine is a much larger amino acid than asparagine. It's a strong ring-shaped structure. So it does change the protein around where this substitution has occurred a little bit. And in particular, this happens to be in the receptor binding domain, which is an important part of the spike protein, because that's the part that plugs into the host cell, and that's how the virus gets in. So essentially, the receptor binding domain is like a key that you're plugging into a lock, and then it turns it, and when the key turns it, the virus rushes into the cell. So there are also some deletions on this particular variant, and these have come out in the news at various times too. So positions 69 and 70 have been deleted. Well, as it turns out, this particular variant probably has been around a lot longer than early December, maybe even a couple months. And it's really all over the world it's been identified, and part of that's because people travel. We suspect it probably arose in the United Kingdom. We don't really know that for sure. It was first identified in the United Kingdom, but it could have arisen somewhere else as well. It is definitely present in the United States. It has been identified in California, Florida, Colorado, and New York, and probably other states at this point too. The fact that it's on kind of in the middle of the country, it's on all of our coasts, it seems highly likely that this particular variant is widespread throughout the United States at this point. All right, on the next slide, let me talk a little bit about the South African variant in contrast to this. So this particular variant arose late in December, and this also has this important N501Y mutation. So this is within the spike protein and within the receptor binding domain, so the key that allows the virus to plug into human cells. So it has the same mutation. It arose independently of the one in Great Britain. It does not have the deletions at positions 69 and 70, but it does have two other non-synonymous mutations, and one of those, this E484K, also occurs in the receptor binding domain of the spike protein. So what are the consequences of some of these mutations? So the first one, the UK, there was concern, and some of this was in the media too, about will it affect laboratory tests? So the United Kingdom has a widespread use of an antigen test. And initially there was concern, well, this isn't going to work for our antigen test, and how are we going to diagnose this? Well, after careful review, Public Health England came out with a statement just in the last few days, I believe, maybe it was a week ago, basically saying, yeah, the antigen test works just fine. So good news from that standpoint. The statement from public health officials in the UK and also the CDC have stated there is no concern at this time that this particular variant will affect the ability of the vaccine to work. So that's good news. So with regard to the South African variant, there's a slightly different issue in terms of the receptor binding domain. Again, that's the key that allows the virus to plug into cells. And a health official at the UK, one of the health ministers, stated that perhaps there's more concern with the vaccine and the South African variant. This was just a statement of concern. There's no data that I'm aware of, nothing that the CDC has put out to say that there is any concern with the vaccine and the South African variant. So why was this statement made? And I don't know for sure, but my speculation is that it's because there are multiple substitution mutations within the receptor binding domain. So the vaccine targets actually the entire spike protein, or nearly the entire spike protein, and we want to preserve as much of that as possible to get the vaccine to work. So if the virus starts mutating in ways that it doesn't look like the original virus, then the concern is that maybe the vaccine won't work. So really all that's changed in the receptor binding domain is that we've gone from 1 to 2 substitution mutations, and then we've also got another mutation that's somewhere else in the spike protein. So the spike protein itself has about 1,200 or 1,300 amino acids in it. The receptor binding domain has maybe 225. Those are approximate numbers. So 1 out of 225 versus 2 out of 225 in the receptor binding domain, it's not a huge percent of what's going on. So I think that gives us some reassurance. One of the things that one of the messages I would like to make sure I communicate is that we don't really have to worry about a super mutant where we have every single amino acid on the receptor binding domain changing to something else. So that would be a challenge. So if, say, that happened and then we're wondering, is the vaccine going to work for this particular variant? Well, it may not. I mean, everything has changed. But when everything changes, that's usually a game over event for the virus. So this virus has to conform very, very closely to its current shape in order to effectively get into the ACE2 receptor in human host cells. So if it changes too much, it's what's called a dead-end mutation. So the virus can no longer get into the host cells, can no longer replicate, and then it's all over for that particular mutation. So the mutations that we're seeing are really just tweaking the virus a little bit. And the hope is that the vaccine will continue to work well against this tweaked virus, and there are lots of reasons to think that it will. The vaccine generates a whole host of antibodies. When you get the vaccine, it's not that you produce just a single antibody to this particular vaccine. In fact, you produce antibodies that target all sorts of patterns that are within the vaccine itself. So if one of them changes a little bit, you've got other antibodies that are there to fight it. So I think that's the concern about the vaccine right now is I'm not seeing any definite information that says that we have to worry about this. So how do we don't want to dismiss this and ignore this. So how do we follow along? So there are 87 million documented cases of SARS-CoV-2 worldwide. There are many more, but this is how many have been documented. 275,000 of those have had their sequence identified, and these sequences have been stored in public databases. There are some others that may not have been stored or uploaded yet. The United Kingdom leads the world in sequencing. So they've done 125,000 viruses. The United States is at about 51,000. Sequencing is labor intensive. It's hard to do, but it is important in terms of monitoring how viruses evolve. So on the next slide, the CDC has in place a program called NS3, and what that stands for is the National SARS-CoV-2 Strain Surveillance. So what this is that all the states and territories on a regular basis, I think it's weekly or it may even be biweekly, send specimens to the CDC, and these viruses have their genome completely sequenced. And so that gets evaluated, put in a database, and so they can track and see how things are changing. The CDC is also involved as a lead in the program called SPHERES, which is the Sequencing for Public Health Emergency Response Epidemiology and Surveillance. So this puts together not just the CDC laboratories, but all kinds of laboratories. I think there are over 150 labs involved with this. These are state public health labs, these are academic laboratories, these are industry laboratories. They're all working together to document what sequences have been encountered, and so we can keep an eye on the fingerprint, the RNA fingerprint of this virus. So it is labor intensive, but it is an important part of our national biosecurity to be monitoring this on a regular basis to make sure that we're looking for significant changes. So on the next slide, to conclude here, so mutations are not new. They have been present from the get-go with this virus, and they will continue to be present. Right now, there is no concern from the CDC that mutations will affect vaccine performance. The truth is, we don't really know, and I don't want to mislead people and say there's a guarantee that the vaccine will always work. That may not be the case. But right now, there are no warning signs or any information coming from public health authorities that the vaccine will not work. Ongoing surveillance is needed and is underway as part of monitoring for the risk of developing problems. But kind of a hopeful note to end on, the vaccine is 95% effective by the reports. Now, we hope that that's true in clinical practice too, but the studies that were submitted to the FDA, 95% effective. That's incredible for a vaccine. So like measles vaccine is up there, but most vaccines are way less than that. When you have a vaccine that's 95% effective, you have a lot of reserve. So if there is a mutation that occurs, well, you still have a lot of ability, a backup ability to fight the virus. Flu numbers are down, but we suspect that a lot of this has to do with the aggressive non-pharmaceutical interventions that are in place. So wearing masks, frequent hand hygiene, not only does that help to reduce the spread of COVID, but it also helps to reduce the spread of influenza. So last spring, when all this started, we had influenza and COVID in the community, and then when people started wearing masks, our influenza dropped down. The experience in the southern hemisphere this past summer, so in the southern hemisphere, our summer, their winter is where they see their influenza season. There was almost no influenza in the southern hemisphere. So we've all been kind of hoping that there wouldn't be much of an influenza season here because of masking. Of course, we won't know that till we get through the winter, but right now we are testing for influenza and we are not seeing much of it at all. COVID is a novel. This is a novel virus, so there's a lot more potential for transmission because there are many hosts that have never seen this. Everyone's seen influenza, and there could be, we could have a situation where the reverse is true, where masking keeps COVID down, but not a novel influenza. I mean, there was a novel influenza in 2009, and there could be another one again, anytime. So it has more to do it's not that masks work for influenza and don't work for COVID. Masks work for both, but COVID is a lot more transmissible, and there is a much, much larger population of people who have never seen the virus. There's actually some debate about that. The UK has suggested that the new strain there is more transmissible. Other health authorities have said, well, maybe not. We don't know for sure. The way that they look at this best is really how many strains are in the community. So what they found over a period of just a few weeks or a month is that most of the strains in the southeast of England converted to this new variant. So that tells epidemiologists that this strain outtransmits other strains of the virus. So it's not that there's a particular property of the virus that they can look at and say this is, is 50% transmittable, the other is 30% transmittable. It's really how it works in the wild. They're just measuring how many of these particular strains they are seeing in their genomic surveillance. So when a strain is more transmissible, can it lead to more hospitalizations? And the answer is yes. So that depends on the virulence, but right now everything we've been told is that this new strain in the UK is no different in virulence than previous strains. So if you have a strain that is equally virulent but is more transmissible and can be passed on to a larger population, then you are at risk of having higher hospitalizations. Of course, the sooner people get vaccinated, if people are practicing good distancing, wearing masks, all of those help to reduce transmission and reduce hospitalizations. Everything that we know now is that we believe that the vaccine will continue to work. We don't know for sure. We'll have to wait and see, and we certainly hope that that is the case. There are many compelling reasons to think that that will be the case, but only time will tell. And so that's one of the reasons we recommend the genomic surveillance. Does the community need to know about this? Not necessarily. I don't think that everyone has to be aware of these mutations, but nevertheless, this question seems to be coming up, and we sure hear about it. I sure hear about it in all sorts of media sources. It's an interesting part of the virology of this virus, and I think it's good for the community at large to be aware that this virus is not static, It changes, and we should not let our guard down. This is a virus that if we let our guard down, it can come back to bite us badly. So, I think that's one of the reasons to be aware of the mutations, the potential risk for mutations.